Hello, I'm very glad to welcome all those who is looking forward to improving their knowledges in the field of medical radiology and present for you topic of our next lecture. It's chest imaging. Today we will concentrate on diagnostic of anatomy and diseases of respiratory and cardiovascular system. Let's start with thoracic imaging and first talk about possible diagnostic modalities. What can we propose in diagnostic of respiratory system, anatomy and diseases? First is plain chest ray examination or conventional X-ray. Then computed tomography, magnetic resonance imaging, ultrasound, and nuclear medicine procedures. Let's observe advantages and disadvantages of every of these diagnostic approaches. Chest X-ray up to nowadays is most frequently used primary imaging for chest. It's cheap, widely available, fast, gives low radiation and portable in patient in bad conditions. Frequently it's possible to make diagnoses such congestive heart failure, pneumonia, pleural effusion, malignancies only with plain or conventional X-ray. But many findings needs in further to be confirmed by further investigations such as CT. Computed tomography is the main advanced imaging of the lung, primary imaging in certain indication. It's less accessible than conventional X-ray, but more accessible than MRI. Main negative is radiation. Nowadays, computed tomography is the main source of iatrogenic radiation in radiology. Usually, computed tomography study expose patient to irradiation to X-ray in doses that are up to 50 times higher than doses used in conventional X-ray. Different terminologies for computed CT. Usually we used term CT scan, but other names also are in use. For example, high resolution computed tomography, computed tomography angiography, computed tomography embolism. They reflect different protocols of study. If you want to minimize doses from diagnostic CT, you will decrease exposure dose of X-ray. What will we obtain? Let's look on these three pictures. You see that in usual CT study, the picture is quite well, and you may identify organs and tissues in details. With decreasing of the dose, picture becomes more and more poor. So the lower dose, the lower resolution. And we shouldn't avoid, due to this fact, we shouldn't avoid irradiating of patient in doses that are necessary to obtain clear picture. Another very nice and very important option of CT is the possibility to perform CT-guided biopsy, especially of peripheral pulmonary lesions. During this procedure, under CT control, a needle is inserted into the lesion and samples are taken for further cytological or morphological examination and for confirmation of diagnosis, especially malignancies. Magnetic resonance imaging. In thorax, it plays important role in cardiac and vascular imaging, as well as imaging of chest wall and bone, but very limited role in lungs. MRI is generally worse in lung imaging than CT. Why? Because MRI imaging is based on detection of vibration of hydrogenium atoms. Lungs contain not a lot of water, no much amount of hydrogenium atoms, and poor picture of MRI image as a result. MRI in chest is a focal exam. It needs specific location, and in thorax mostly for further clarification on finding on CT, for example, for thymus, cystic masses in mediastinum, and so on. So CT is better than MRI for lung because spatial resolution better with CT for lungs. It's faster. CT is much faster than MRI. It takes much less time for diagnostic procedure. Certain scanners can image entire chest in less than 1 second. Next point that lung is a natural contrast agent, and MRI poor for lung signal because lung consists no water but consists air. Look at this picture and ensure that CT is better for lungs than MRI. In the left part of picture, two MRI images in which we can identify very few details, and on the contrary, computed tomography scan on the right part of picture presents us image of lung and mediastinum and heart in very details. So, imaging of lungs, start methods may be CT, but then confirmed by CT investigation, or you may start with CT at once. So two options, conventional X-ray and CT or their combination, predominantly used in diagnostic of respiratory system. Ultrasound is increasingly used in medicine in recent decades. Previously specialized radiology and expensive, now becoming more and more widely available. Ultrasound has limited role in imaging of lung because it cannot penetrate air, so cannot give us images of lungs, but it's very useful in assessing of pleura and for interventional procedures. Look at this picture. It's plain X-ray of chest with huge amount of pleural infusion in left pleural cavity. Can you answer the question, what is the volume of effusion? No, plain X-ray doesn't give us opportunity to answer this question. But if we proceed with ultrasound investigation, we will get answer. A plain X-ray performed in upright patient position reveals the pleural infusion more than 20 milliliters, whereas ultrasound examination will show us a small amount of effusion, about 15 or 20 milliliters. And besides, it gives opportunity for aspiration and cytological evaluation of liquid. Chest X-ray main views, main projections are posterior anterior and anterior posterior and lateral. Usually posterior anterior and lateral projections are widely used. Effect of projection on apparent heart size. Projection is very important because look at this picture and compare size of heart, which is shown in red, if the patient is placed with the heart near detector and from some distance from detector. In posterior anterior position, size of heart on the film on the detector corresponds to a real size, and when we change position to anterior posterior, heart looks to appear bigger than it is indeed. General technique of study in fluoroscopy or röntgenography is the following. Patient is placed as close as possible to screen or to the detector, and source of irradiation or X-ray tube is placed on certain distance up to 1.82 meters from the patient, and films are taken in posterior anterior projection. Next very important thing is densities which may be distinct by human eye or plain X-ray films by eye of radiologist, of operator. There are four densities that can be easily distinct by human eye. From least opaque and most lucent to most opaque and least lucent structures, we will see something in completely black color, it's air or gas, and something completely bright in white color, it's bone or calcification. All the rest, such solid organs or fat, occupies intermediate position and are presented in dark gray or light gray colors. Lung anatomy or chest anatomy on plain X-ray films. Usually on every plain X-ray film you can identify first of all so-called lung fields, left and right, and middle shadow, which is formed by shadow of heart and great vessels. Very important diagnostic points are aortic arc, shadow of pulmonary trunk, shadow of contour of left ventricle and right atrium, HeLa of lungs or shadows of great lung vessels and bronchi. Here is example of normal chest X-ray, and all structures are arrowed. You will easily find them with the help of arrows, and I will not comment this picture. When you will look through this presentation and home, just stop and look attentively for image and for arrows. In lateral projection, also lung fields, parts of lung fields and middle shadow is present, and very important thing are retrosternal and retrocardiac space, because in case of heart enlargement as a result of congestive heart failure, for example, this space, retrosternal and retrocardial, disappear completely or essentially diminished. Here is projection of lungs on body surface is shown. You remember that right lung consists of 3 lobes, superior, middle and inferior, and left lung consists of only 2 lobes, superior and inferior. Lung anatomy on chest X-ray. Let's continue and observe where should we look for certain lobes of lungs. The right upper lobe occupies the upper 1/3 of the right lung. Posteriorly, the right upper lobe is adjacent to the first 3 to 5 ribs. Anteriorly, right upper lobe extends inferiorly as far as the 4th right anterior rib. Right middle lobe, right middle lobe is typically the smallest of the 3 and appears in triangular shape, being narrowest near the hilum. Right lower lobe is the largest of all 3 lobes of right lungs, separated from the others by the major fissure. Posteriorly, the right lower lobe extends as far superiorly as the 6th thoracic vertebral body and extends inferiorly to the diaphragm. Review of lateral film surprisingly shows the superior extent of right lower lobe. The lobar architecture of left lung is slightly different than the right, because there is no defined left minor fissure. There are only 2 lobes on the left, upper and lower lobes. On lateral films, left upper lobe and left lower lobes, and then we continue with the segmental structure of lungs. There is no way to facilitate memorization of location of different lung segment. You should learn it by heart or review your knowledge from normal anatomy. Just remember pictures from atlases of normal anatomy, and I should ensure you that this picture will correspond with images of different segments of lungs presented on this slide. How to examine chest X-ray? How to make conclusion? First step is evaluation of patient position. Correct position, we tell about correct position. Well, shadows of thoracic ends of clavicles are arranged symmetrically above the spinosus process of vertebra. If the patient is turned to right or to left side, right or left lung will seem to be smaller than it appears indeed, smaller and darker. Exposure, very important thing which allows to conclude is X-ray film good or bad take. Exposure shows how dark or light a film is, and in normal exposure you should see vertebral bodies through shadow of the heart. You may compare that in normal exposure all structures as bones, middle shadow, lung fields with details of lung patterns are present. In insufficient and excess exposure, small details disappear and you cannot make proper conclusion about status of lung and presence or absence of lung pathology. Inspiration. Usually, before taking X-ray film, you ask patient to inhale as deeply as he can. In case of inadequate aspiration, frontal segments of only 4 ribs can be seen, and cardiac silhouette looks dilated, lung looks to be condensed, and in supradiaphragmatic parts. All these changes disappear after adequate aspiration, and X-ray film is coming to normal. With adequate breast must be distinguishable posterior segment of the upper 9-10 pairs of the ribs and anterior segments of the upper 5-6 pairs of the ribs. All they are shown, and at home please stop at this slide and look through this picture more attentively. Projections of posterior and anterior segment of ribs. How to recognize where is posterior, where is anterior end of ribs. Usually posterior part of ribs goes horizontally and anterior from top to down in oblique direction. May X-ray syndromes of pulmonary pathology. 3 large groups of symptoms of syndromes may be found. shadowing of lung fields or consolidation, clarification of the lung field, and changes of the pulmonary and Hillis pattern. Shadowing. Whenever you see an area of increased density within the lung, it must be the result of one of four processes. First, consolidation. Any pathologic process that fills the alveoli with fluid, pus, blood, cells, including tumor cells, or other symptoms resulted in lobar, diffuse, or multifocal ill-defined opacities. Interstitial involvement of surrounding supporting tissue of the lung, resulting in fine reticular opacities or small nodules in lung fields. Nodule or mass, any space occupying lesion where normal lung tissue is substituted by something else, for example, for tumor mass. And at last, atelectasis, collapse of part of the lungs due to a decrease in the amount of air in the alveoli, resulting in volume loss and increased density of some part of lungs. The shadow of lung field depend on size and shape. The majority of respiratory diseases is attended by induration of lung tissue or reduction of the lung tissue airness, which leads to the appearance of shadow or shadowing on the background of light normal lung field. Shadowing may be total, limited, rounded, ring-shaped, or patchy. Total shadowing affects the whole lung as a result of complete blockage of main bronchus by tumor or foreign body and atelectasis of the whole lung. Limited shadow of lobe or segments or several segments can depend on atelectasis or inflammatory or pleural effusion. Rounded shadow, circle in shape, oval, more than 1 centimeters in size, can be formed by different pathologic processes such as eosinophilic granuloma tuberculosis, pneumonic infiltration, pulmonary infarction, closed cyst, aneurysm, benign tumors, or malignancies of lungs. Ring-shaped shadows means the formation of cavity with level of liquid in the lower part and gas in the upper part of cavity. It's usually a sign of cysts, abscesses, tuberculosis, and peripheral lung cancer cavities with disintegration. And at last, small patchy shadows are most often multiply and occur in disseminated tuberculosis, focal pneumonia, lung metastasis, and pneumoconiosis. This picture will, I suppose, facilitate you to imagine how total, limited, and other types of shadowing looks at plain X-ray film. Total shadow of the lung is usually caused by atelectasis, hydrothorax, or typical total pneumonia. Differential diagnostic is based, first of all, on the position of mediastinum. In atelectasis, mediastinal shift occurs sideways to the shadowing, Hydrothorax, on the contrary, force mediastinum to shift to the healthy side, and total pneumonia, usually no mediastinal shift occurs. And in this picture, you may ensure that in case of massive left pleural effusion, mediastinum shadow is pushed to healthy side, and on the contrary, in case of atelectasis of the whole lung, shadow of heart and great vessel is pulled to the same side, to the side of pathology. The main causes of limited shadow of lung fields are inflammation, atelectasis, and fibrosis. This table will allow you to provide differential diagnostic of these 2-3 pathologies. First, pattern of shadowing. Usually, shadowing is inhomogeneous both in inflammation and fibrosis, and atelectasis presents homogeneous shadowing. Lower limit of shadowing in inflammation, lower limit usually is flat or upwards because affected lobe is enlarged. And in atelectasis, in cirrhosis, in both these cases, lower limit of shadows is pulled upwards because lobe is diminished as a result of poor ventilation in atelectasis and as a result of development of connective tissue in fibrosis or sclerosis. And mediastinal position, the same changes happens as in total shadow of lung fields. Inflammation causes no changes, and atelectasis shifted mediastinal sideways to the pathology, and on the coast and as well as fibrosis also pulls mediastinum shadow sideways to pathology. Changes of lung pattern. First of all, a few words. What is this lung pattern? In healthy human, lung pattern is formed by arteries and veins, shadows which are located in the lungs at the different angles of the X-ray beams. The lung pattern is copious in the hilus zone, but only small vascular branches can reach the periphery of lungs fields and can be seen there on the periphery. Signs of the normal lung pattern are, first of all, correctness of the branching, flagellate going of the elements from the hillock to the periphery, continuous and gradual diminution of the site from the hillock to the periphery, and contour sharpness. Variants of lung pattern pathology. 3 main syndromes may be described: increase, impoverishment, and deformation of lung pattern. First, increase of lung pattern is defined by the increased amount and size of its element in the unit area of the lung field. Usually it occurs as a result of the standard plethora of small circles. For example, in cases of septal defects, ductus arteriosus, mitral stenosis, left ventricular failure. The other reason is the development of connective tissue in the interstitium of the lung, in pneumosclerosis, as a result of chronic inflammation. And at last, the last reason, main reason, is the edema of interstitial tissue with acute inflammation. Impoverishment of lung pattern is one of reason of this phenomena is obstructive syndrome and emphysema. When areas of microatelectasis are combined with the local limited increase of ANS of the pulmonary tissue. Is in this picture as an example of impoverishment. You see that lung pattern is very well seen in HeLa region, but at the periphery of lungs we do not observe presence of lung vessels. And deformation of the lung pattern is defined by the change of normal motion and normal form of the elements of the pattern. As a rule, it's combined with enhancements of the pattern, and the main reason is inflammatory infiltration, pneumosclerosis, which develop in the place of previous inflammation, most often observed with chronic bronchitis, with diffuse pneumosclerosis, with pulmonary tuberculosis, different types of pneumoconiosis, or fibrosing alveolitis. Changes of the HeLa, different pathologies may lead to very similar changes of HeLa images on plain X-ray, infiltration, enlargement, and calcification in areas of previous tuberculosis, enlargement of HeLa lymph nodes as a result of tubercular lymphadenitis. All these structures, all these pathologies makes HeLa more huge, enlarged on plain X-ray films. Inflammation of lung tissue, most typical is pneumonia, total, lobar or segmental, and common stages of radiographic stages of pneumonia are at first early changes as hyperemia and plethora of lungs. Stage 2, pronounced inflammation, exudation into alveoli of blood plasma, which also contains white blood cells, red blood cells, fibrin, and bacterial flora. And so induration on the lung tissue of alveoli happens. And second and third stage is resorption of previous changes. For example, look at left-sided pneumonia, infiltration of the upper section of axillary part in left lung, in posterior, anterior, and lateral projection. Types of pneumonia, macrofocal or microfocal, depends only on the size of 40, macrofocal usually more than 1 centimeter, and microfocal several millimeters, not more than 1 centimeter. Results of pneumonia, possible results of inflammation in lung tissue are complete resorption, formation of abscesses, so it's a complication of pneumonia, and at last formation of pneumofibrosis for the rest of patient life. In acute respiratory illnesses, it's very important to make proper diagnosis and remember about the phenomena that not all changes of lung tissue pathology will be present on plain X-ray films. For example, in patient with normal chest X-ray, 45% have pathological findings on computed tomograms. So don't avoid to administrate CT scanning if you are confronted with normal conventional X-ray. Some common pathologies of lungs and bronchs. First, chronic obstructive bronchitis. The X-ray and CT in chronic obstructive bronchitis exhibit a triad of symptoms: bulking of the connective tissue in the lungs, emphysema and pulmonary hypertension, and third, relatively small size of mediastinal or median shadow. Bulking of connective tissue is the enhancement and deformation of the lung pattern, especially in the hilus area, and fibrous deformation of the lung hilum. Emphysema may be found as increase of size of lung fields, flattering and low elevation level of diaphragm domes, reduction of respiratory excursion of the diaphragm, transparency of lung field undergoes very little change on the inspiration and expiration. Large branches of pulmonary artery are dilated, but then their diameter dramatically decreases, so-called symptom of hilus stump. And a small size of medial shadow occurs due to the swelling of the lung tissue. And this is just example of chronic bronchitis with deformation of lung pattern with the absence of the lung pattern in the peripheral part of lungs, and formation of huge emphysema bulls in lungs in frontal and lateral projection. The same is on the axial slides. Degrees of bronchial possibility disorder. First phase is hyperventilation. When obstruction is not complete and air can pass through the blockage, but in not enough amount, and the affected part of lung is hyperventilated. So-called next step is so-called valvular emphysema, when bronchus delayed in inhalation and lets air to go into the alveoli, and in exhalation, when bronchus is constricted, uh, complete complete blockage of bronchus occurs, and air cannot go out of alveoles, and this leads to formation of valvular emphysema. And the third step is complete blockage of bronchus and complete atelectasis of affected lobe or whole lung. Pulmonary tuberculosis, it's very huge topic, and I can't present you all possible changes that may happen in pulmonary tuberculosis. But I think this table will be helpful for you. Why? Because here you can find most frequent forms of pulmonary tuberculosis. In adults, it's infiltrating forms of tuberculosis, and in childhood, predominantly lesions of intrathoracic lymph nodes. About 40% cases of tuberculosis in childhood are tuberculous lymphadenitis, and about 60% of adult tuberculosis are different infiltrating forms. The rest, development of cavities, fibrosis, cirrhosis, forms of tuberculosis are much more rare. Phases of tuberculosis inflammation are follows: infiltration, disintegration, seeding, resorption, induration, scarring, and calcification. And all these phases may be detected as on play X-ray films, and of course more details in CT scans. Fluid, presence of fluid in pleural cavity also may be detected. First of all, let us say that there is 3 or 5 milliliters of lubricated fluid in pleural cavity in healthy persons, which of course is undetectable by conventional X-ray. The effusion detectable by ultrasound is detectable by ultrasound when its volume expands up 15 or 20 milliliters. And the effusion volume that can be detected by plain X-ray examination depends on the projection of patient, and volumes that may be detected in different projection are shown on this picture, from 50 milliliters in lateral projection up to 1/2 liter or even 1 liter in lying position. Lung cancer, very challenging problems in oncology. There are central and peripheral forms of lung cancer. Central cancer comes from the epithelium of central lobar or segmental bronchus. The main symptom on the X-ray film is hyperventilation and atelectasis, the prevalence of which is due to the size of the affected bronchus. It may be total atelectasis, atelectasis of the lobe or segment. The main radiological signs of atelectasis are homogeneity of the schedule and mediastinal shift sideways to the pathology, pulling up to the pathology. Peripheral cancer comes from the bronchi smaller than segmental, and the X-ray picture shows a single lesion focus in the lung. Characteristic of this focus are small size. The limit of legibility of the X-ray picture is 3 millimeter. Of computed tomography scan is about 1 millimeter. Low intensity of the shadow. This intensity is weaker than a shadow of tuberculoma or benign tumor. Usually peripheral cancer is rounded form, rarely triangular, star or diamond-like. Focuses 40 of peripheral cancer usually have blurred contours compared to the shadow of cyst and benign tumors, which have regular contours. Calcification usually are absent in peripheral sites, in peripheral cancer sites, and this form of cancer shows a tendency to rapid growth. Tumor doubling time depending on the degree of differentiation of cancer is about 45 or 450 days. Here is example of central cancer of upper lobe of right lung bronchus. Here is shadow of tumor, which causes shadows of tumor, which causes complete blockage of upper lobe bronchus, and as a result, atelectasis of upper right lobe. Here is example of peripheral lung cancer on X-ray film and on CT scan. Of course, CT scan provides much more details. Another option in diagnostic of lung pathology is perfusion scintigraphy, using of radioactive tracers which are accumulated in lung tissue, and they will be not accepted by cancer cells, and the absence of radioactive drug accumulation will show us presence of cancer. For example, as in this picture, central cancer of upper lobe of right lung is shown. Another pulmonary pathology is pulmonary embolism. Conventional X-ray is of no value and can cannot exclude the presence or absence of pulmonary embolism. Usually limited and non-specific findings as small effusion and atelectasis may be confirmed by X-ray, but not more. Main reason for X-ray examination in suspicion of pulmonary embolus is to look for other cause of patient symptoms. Computed tomography has become the investigation of choice in pulmonary embolism and also can find other causes or of symptoms. You see that CT scan on this picture shows a brick of pulmonary vessels at the level of main pulmonary arteries. Nuclear medicine is very helpful and traditionally investigation of choice even prior to CT scans, of course in clinics, in departments which can maintain these techniques. Nuclear medicine, SPECT, CT or PET has primary role in assessing for chronic pulmonary embolic disease. Results of nuclear medicine study are usually described as probability. For example, after nuclear medicine examination, we can say that pictures are normal or nearly normal, low probability of pulmonary embolism exists, moderate probability or high probability. Disadvantage of nuclear medicine diagnostic is the fact that lung consolidation, underlying lung disease can affect results. Here is example of perfusion lung scintigraphy, which shows thromboembolism of main branch of the pulmonary artery, reduction of the radioactive drug accumulation in left lung. And we, of course, we can't pass the worst nightmare of the whole mankind, COVID-19. I will not tell you about epidemiology, mortality, and other things connected with COVID-19, only from radiological point of view. First of all, X-ray is not reliable, and only CT may confirm diagnosis, presence or absence of pulmonary lesions. Sensitivity of CT in COVID-19 is up to 100%, but no specific finding you will meet on CT scans. Next point is the fact that we need frequent CT examinations, even every 4 days, for timely assessment of rapid dynamics and changes in treatment tactics. Usually, this pathology presents bilateral involvement and multiply lesions in lung tissue. The primary CT pattern of COVID-19 is a picture of so-called ground glass infiltration of pulmonary lobes, followed by a decrease in the lesion volume with favorable development of events, or the increase or addition of CT pattern, so-called crazy paving or crazy kill, with an unfavorable progress of the disease. And of course, if you do not observe nothing specific, you may always confirm CT diagnosis of COVID-19 by clinical symptoms or by the result of polymerase chain reaction. And now let's go to cardiovascular imaging. Nuclear radiology, echocardiography, cardiac magnetic resonance, computed tomography, and angiography. As you see, the diagnostic modalities are the same than in investigation of respiratory system, but they are listed here in different order. Let's try to understand why. Comparative spatial resolution of different methods of investigation is presented here. You see that ultrasound, MRI, and CT are very good, very precise in detection of small lesion, so they reflect predominantly status of structure of heart and large vessels, and on the contrary, signal photon emission computed tomography or positron emitted tomography can detect lesions about 10 millimeters, which much bigger than other modalities, but advantage of nuclear medicine procedures is possibility to evaluate function of organs, not structure, but first function of myocardium. Assessment of myocardium viability is based on cardiac MRI and positron emission tomography metabolism perfusion with Thallium 201. Low dose dopamine, in other words, ultrasound with low dose dopamine substance administered as contrast agent for ultrasound also may be helpful. So start with cardiac MRI. Proceed if you have such possibility with nuclear medicine, with PET metabolism and perfusion study with thallium, and if you have no possibility to use to administrate cardiac MRI or PET, then use ultrasound examination. Assessment of cardiac function. First step and very reliable data may be obtained from ultrasound examination. Then further information will be get from nuclear studies, cardiac MRI, and cardiac CT. Cardiac shunts, their status, their function, is it sufficient or insufficient, may be evaluated after ultrasound examination, nuclear first pass study, and also MRI and CT scans, but two last modalities are less sensitive than echocardiography and nuclear medicine studies. Pericardium may be assessed by transthoracal or transesophageal ultrasound or echocardiography, also with cardiac MRI or cardiac CT, but usually echocardiography is enough to make proper diagnosis of pericardial effusion and even to take sample of pericardial liquid for cytological examination. So, what summary of all above is the table which shows priority methods of diagnostic in cardiology. You see that most of problems may be solved with the help of ultrasound, which shows morphological changes in the heart, functional state of myocardium, file function of valves, and presence or absence of regurgitation, for example, pathology of mitral and aortic valves, and so many ejection fractions. I can't tell you what is impossible for ultrasound examination, really. If we need to concentrate predominantly on anatomy of organ, we will choose CT or MRI. If we are confronting with moving structures, for example, with blood flow in peripheral vessels or with moving heart valves, we will use ultrasound with Doppler function. And for evaluation of coronary artery lumen, radiopaque coronary angiography is preferable. It is replaced in last years by CT with contrast enhancement, but still in use. Ultrasound is the easiest, most easy, portable, and cheapest cardiac imaging modality. It's harmless, provides real-time imaging of regions of the heart, different regions of the heart. It has high resolution and have possible improvements, for example, three-dimensional reconstruction or addition of Doppler function for echocardiography. Application for Doppler in echocardiography, its most common techniques used for detection and evaluation of severity of valvular regurgitation. Also characterization of aortic stenosis, presence of aneurysm or pericardial effusion. Here is posterior anterior chest X-ray with different structures of heart and great vessels looks very similar to those which we have observed in the part devoted to diagnostic of respiratory diseases. CT provides more detail about heart position and structure and allows to visualize localization of different heart chambers in chest cavity. Usually, as you see from the pictures, its level of slide, usually right atrium forms right heart border and right ventricle forms anterior heart border. Left chambers, left atrium forms completely part of posterior heart body and left ventricle forms left and posterior heart border. MRI in cardiology has advantages and limitations. In comparison to other techniques, cardiac MRI offers improved soft tissue definition. Dynamic imaging provides functional assessment of myocardium. It uses no ionizing radiation, but at the same time, the limitation is that MRI is generally inferior to cardiac CT for evaluation of coronary arteries. Indication for administration of magnetic resonance imaging in cardiology are following. Tissue damage, MRI allows to reveal tissue damage from a heart attack. Then reduced blood flow in the heart muscle as a cause of chest pain, angina. Problems in the aorta and in the heart's main artery, such as rupture, aneurysm, or narrowing. Diseases of the pericardium, such as effusion or constrictive pericarditis. Heart muscle diseases, such as heart failure or enlargement of the heart, and abnormal growth, such as malignant tumors. Also, MRI allows to reveal heart valve disorders such as regurgitation and congenital and acquired heart defects and the success of their surgical repair. Nuclear medicine in cardiology, single photon emission computed tomography, or also called myocardial perfusion imaging with thallium or technetium, used to measure blood flow through the heart and to detect areas of abnormal heart muscle. Information obtained from SPECT scans can be used to identify blockage in the coronary arteries, determine whether someone has had a heart attack, try to predict those persons at high risk for heart attack, and assess a patient condition after bypass surgery or angioplasty. Coronarography is a special approach contrast X-ray study when a catheter is inserted into femoral artery and passed under fluoroscopic guidance in retrograde direction through abdominal aorta, then through thoracic aorta, aortic arc into left ventricle up to the mouth, first of the left and then of the right coronary artery, and then automatic injector infuses radioactive substances in small amount, about 5 or 10 milliliters, and produce time-lapse or video. What can we see in coronarograms? First of all, we can evaluate the degree of narrowing of the coronary artery lumen and establish the level of this narrowing. Usually we say that grade 1 is 40% of narrowing, grade 2 from 50% of narrowing, grade 2 from 50 to 75%, grade 3 more than 75%, and grade 4 complete coronary artery occlusion. Usually it's very important information for surgeons because critical stenosis more than 75% of coronary artery lumen is indication for urgent surgery, for shunting or angioplasty. So also coronary angiography can show us unfavorable prognostic factors. First of all, it's the lesion of the left coronary artery. It's not well. Second point is three-vessel disease, so-called three-vessel disease. Left anterior descending branch of left main coronary artery, circumflex branch of left main and right coronary artery. In three-vessel disease, disease prognosis is much worse than, of course, if lesion occupies only one branch of coronary arteries. Next unfavorable prognostic factor is narrowing of coronary arteries by 75% or more, especially complete occlusion of coronary artery, and poor development of collateral circulation, also not so good for patient. Except coronary arteries angiography or contrast X-ray study may be used for study and evaluation of peripheral vessels. For example, here critical stenosis of common artery of left common iliac artery is shown on X-ray film, and after angioplasty, angiography confirms that circulation is, blood flow is in this region became normal. And at last, we have no time to observe different heart pathology, but I can't say no words about congestive heart failure. It's the result of insufficient output because of cardiac failure, high resistance in circulation, and fluid overload. Uh, we may detect left ventricle or right ventricle failure. Both of them have different mechanisms, but both results finally in edema of pulmonary fields and increased pulmonary venous pressure, and resin edema as a result of it. Main symptoms which may be found on X-ray or films or computer tomography scans are redistribution, interstitial edema, so-called curly lines, increased heart signs, pleural effusion, and vascular pedicle enhancement. Redistribution, what does it mean? It's redistribution of blood from pulmonary vessel supplying the lung basins to the vessels supplying the upper part of lungs. Uh, Normally, blood vessels in upper regions are smaller and fewer in number than a vessel in lower part of lung. And in heart failure, blood from lung from lower parts of lung redistribute into the upper lobes. Interstitial edema is the result of fluid leakage to the interlobular and peribronchial interstitium as a result of increased pressure in the capillaries. Curly lines, small, about 1 or 2 centimeter horizontal lines near costophrenic angles. It's image of intralobular septa, which becomes visible as a result of interlobar edema. Increased heart signs or increased cardiothoracic ratio, which is normally is less than 50%, and enlargement of heart will always lead to increase of cardiothoracic ratio more than 50%. Pleural effusion, presence of liquid of fluid in pleural cavity may be detected on posterior, anterior, and lateral fields, usually on 175 milliliters of liquid is visible on posterior, anterior fields, and about 75 millimeters on lateral fields. And if vascular pedicle shadow of great vessel is more wide than 84 millimeters, it shows us that there is increased amount of blood in aortic arc and pulmonary trunk. Is also a reflection of increased pressure in lung parenchyma, lung capillaries and veins. So, thank you for your attention. Don't forget to note about hot drinks and warm clothes, and see you after 2 weeks.